Now it's time to introduce our speaker. Dr. Madeline Weber is a pediatric hospice and palliative care physician with Norton Children's Pediatric Support Team. She earned her medical degree from Indiana University and completed her pediatric residency at Cincinnati Children's Hospital, and then followed that by a fellowship in hospice and palliative medicine at the University of Louisville. Her clinical interests include pediatric palliative care and narrative medicine. She is dedicated to walking alongside patients who have serious illnesses and their families, offering compassionate, evidence-based care with a goal to alleviate suffering and improve quality of life for patients and families throughout their medical journey, ensuring they feel heard, understood, and cared for. So welcome, Dr. Weber, and she's going to be talking to us about pediatric palliative and end-of-life care. I'll turn it over to you.
Thank you so much. I'm going to share my screen here. Hi, everyone. My name is Madeline Weber, and I am a palliative care pediatrician, and I'm here to talk to you all about pediatric palliative and end-of-life care. The learning objectives for this talk are to describe the key components of pediatric palliative care and to review strategies to provide compassionate and evidence-based care that addresses suffering and improves the quality of life of patients and their families. I have no relevant disclosures. So what exactly is palliative care? Palliative care is care that is offered to children with serious illness throughout the illness trajectory. And when you think of or hear the word palliative, I want you to first think of the root of the word palliative, which is pallium, which means to cloak or to cover. And that is exactly what we aim to do. We are really an extra layer of support for patients and their families when they're facing serious illness. And in palliative care, one of our main focuses is providing compassion-based care. And the breakdown of the word compassion is com empati, which means to suffer with. And so that is one thing that we will talk about throughout this presentation is how to walk alongside patients and families who are experiencing suffering and to hopefully not only be able to lean in when we see suffering, but also being able to attend to that. The National Hospice and Palliative Care Organization describes pediatric palliative care as focusing on enhancing quality of life for the child and family and preventing and minimizing suffering. And we do this by providing care that focuses on the holistic needs of the child. And while end-of-life care is a part of what we do and a big part of what we do, it is just that, just one part. End-of-life care is really a distinct period of time where care is focused almost entirely on comfort. And this can be minutes if you think about a patient who's in the ICU, who is being separated from the ventilator. Or this can be longer, weeks or even months, if you think about a patient who has cancer and receives end-of-life care in the home, for example. And it also involves the bereavement period, which starts before the end of the child's life and persists well beyond the child's death, as we know that bereavement for families who have lost a child is very long and complex. So when we think about suffering in medicine, this painting is called The Sorrowing Old Man or At Eternity's Gate by Vincent van Gogh. And if you know anything about Van Gogh, he struggled deeply with depression and mental illness, which we'll talk a little bit more about why that's relevant. But the title At Eternity's Gate really suggests his contemplation of mortality and end of life, which is something that he often painted about in his final months. And so when we talk about suffering, I want you all to think, what do you think of when you think of how your patients suffer? And how would you define suffering? Eric Cassell describes in his book, The Nature of Suffering and the Goals of Medicine, suffering is a state of distress that occurs when the integrity of a person is threatened or disrupted. And this is a personal experience, meaning that while we might have two patients who both have the same type of pain from, for example, a tumor in the same location, they both experience that pain or that suffering very differently. Cicely Saunders is the founder of the modern hospice movement, and she first described this concept of total pain, which is a comprehensive way in which people experience pain at the end of life. But we've since redefined this as total suffering because we know that experience of an illness has a profound impact on both patients and their families. And while some of these experiences or way that people suffer may be visible through the illness itself and the physical symptoms of that, some are also invisible, as you can see here. the emotional factors, the psychosocial factors. There's also existential concerns and disruption to normal living, some of those other things that we don't as commonly see visibly. And so when we think of ways that we address suffering as a medical team, of course, we think about the targeted interventions that we use to treat underlying illness and its symptoms. For example, we use chemotherapy to treat cancer. But we also have to work together to ease suffering using more global interventions, like the way that we listen to our patients and their families, and the way we communicate with them, and the way that we all work together as a team to provide that wraparound care that I talked about earlier. These are some of the more global interventions, and those are really the main tools in our palliative care toolkit as we work to help address patients and families in the way that they suffer and to restore that integrity or sense of self. And palliative care is delivered in multiple ways. And I would challenge you to think about the ways that you already deliver palliative care in your practice. Because first is the child's primary medical team providing primary palliative care. For example, if we have a child with cancer, they'll be cared for by their primary oncologist and the entire interdisciplinary oncology team. And then we think about generalist palliative care. So this is palliative care that's provided by some of those palliative care champions or the clinicians who are already embedded in your units who have an interest in palliative care and have sought additional training in pain and symptom management or in goals of care discussions, for example. And then there's subspecialty palliative care that's provided in a consultative model, which is really what our team provides. And that we do that when the care of the child is more complex or when there's a high risk diagnosis, for example. So, how do you introduce our team? This is something that we get asked all the time. How do I let the family know that you all will be coming? First, this is our wonderful team here at Norton Children's Hospital, and we call ourselves the Pediatric Support Team. And so it's always helpful to use our name when describing our team to your patients and their families. We're an added layer of support for patients and families who are facing serious illness. And our goal as a team is really to begin to integrate palliative care throughout the illness trajectory. And I think something that's important to note on this slide, as you can see, there's no palliative phase of care. And when we often hear someone call a patient palliative or say that a patient has gone palliative, we as a team realize very quickly that we're not doing a good enough job integrating at each and every stage. Because that is really not a thing. We are hoping to be able to integrate during each phase of care, whether it's being present when bad news is shared or the diagnosis is shared, for all patients who have a high risk diagnosis, for example, for patients who have chronic complex medical conditions during those big decision points, such as consideration of long-term mechanical ventilation, or for patients who have cancer that has relapsed, and then as much as possible for patients who no longer have curative treatments available or who are at the end of life. And so often we hear from families or from providers that the worry is that families aren't ready. And so we say, not yet, not yet, not yet. And we really dub this the avocado syndrome, where we wait and we wait and we wait to call our team. And all of a sudden we're like, oh my gosh, you have to come right now. And by then it's too late. The avocado is overly ripe. And so what I would say is that we know from the literature, very few children or parents express opposition to early palliative care integration, and very few patients and parents demonstrated a perceived detrimental effect of early integration of palliative care. In fact, they were significantly more likely to express the palliative care team as helpful for treating symptoms, helping with treatment decisions, and as being an overall positive addition to the child's care, even when integrated early. So while some people might not be ready for palliative care, what we know is it's not the patients or the families. So you might be asking yourself, does integrating palliative care really make a difference? And this is a young field, so the data is not super robust, but what we do know from the adult literature with this Sentinel article for palliative care integration is that in patients with metastatic non-small cell lung cancer, early palliative care led to improvements in both quality of life and mood. And as compared with patients receiving standard care, patients who had early palliative care intervention had less aggressive care at the end of life and longer survival. And since then, we've seen this growing body of literature in the pediatric world that shows palliative care integration in children with cancer, for example, leads to improved symptom burden, pain control, and quality of life, a decrease in intensive procedures, increased completion of advanced care planning and resuscitation documentation, fewer end-of-life intensive care stays, and a higher likelihood of dying at home. Children who received early pediatric palliative care were also more likely to have fun and experience events that added meaning to their life. They reported improved communication and family satisfaction. They experienced shorter hospitalizations and fewer emergency department visits. They had fewer diagnostic and monitoring procedures and improved pain management. And in cancer patients, adolescent, and young adult cancer patients, palliative care integration was associated with fewer intensive treatments, including in the last month of life, less time on a ventilator, fewer days in the ICU, 1 versus 3 intensive procedures, and a DNR 6 days instead of 2 days before death. And so what are the key components of palliative care, and how do we address suffering? I'm going to go through the following, but the core components are compassionate care, communication. We'll talk about hope, regret, and legacy, and we'll talk a little bit about symptom management as well. So how do we provide compassionate care? We start with empathy, and then we take it one step further. And we're going to start with this video.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
And so we start by jumping in the hole, like Brene Brown said, and then we lean in. And how do we take it one step further after that? If sympathy is, I feel for you, empathy is, I feel with you, and compassion is, I'm here to help. And that's really what we're aiming for. And what we know is that compassion makes a huge difference. How many times have you found yourself sitting in a room with a patient or a family member, and all of a sudden you just hear them take this huge sigh of relief, and they say, I feel so much better now. You are the first person who's truly listened to me. Because what we know is even if we completely and utterly fail in curing the illness or, addressing the symptoms, just showing up and loving them makes such a huge difference. Because what we've seen in the literature is that a stronger therapeutic alliance leads to decreased decisional regret and improved psychosocial outcomes for bereaved parents. So how do we do this? How do we build that therapeutic alliance? In a study looking at how oncologists build a therapeutic alliance with patients and families, they noted 7 key ways that they did this. First, with connection. Like Brene Brown said, that drives compassion and empathy. Remembering what our patients tell us and being willing to share about ourselves as well. Providing empathy by naming emotions, expressing understanding, offering our patients and their families praise, exploring feelings and conflicts, and being willing to say sorry when we make a mistake. Being present in the moment, not rushing, offering silence, partnering with patients and families by expressing non-abandonment, using we statements, being accommodating, being inclusive, using open-ended language to elicit goals and wishes, affirming decision-making that families made, using analogies or showing images, humor, using comedic relief or jokes, matching the tone or energy in the room, and then honesty, using a warning shot, being transparent, giving opinions, and summarizing. And a side note for honesty, because what we so often worry about as clinicians is that when we share bad news, we'll decrease hope. But what we know is that disclosure of a terminal prognosis does not mean a loss of patient hope. Instead, hope was redefined on a goal other than cure. And so how do we do this? How do we provide compassionate care? How do we create that therapeutic alliance with all of these things? I think the bottom line is really communication. And if you're like me, you love Harry Potter. And Dumbledore said, words are, in my not so humble opinion, our most inexhaustible source of magic, capable of both influencing injury and remedying it. So our words really matter. Communication should always be honest, culturally and developmentally appropriate, timely, and centered on the child and their family. And when I think about communication in palliative care, I think of 5 core questions that we always ask to help develop a plan of care for a patient and their family. And this is really the core 5 questions for what we call in palliative care a goals of care discussion. And the ways I often conceptualize these 5 core questions is using a model described by Chris Feutner, who's a bioethicist out of Philadelphia. And he developed this space model of decisional support where we are all standing together in a room with the walls around us. And we start with the center of the room, which is always the child and the family. And we ask the family to tell us more about their child. And so often when we walk into a room and we ask that question, tell me more about your kid to a family, they start by listing off their entire medical journey and telling us all the medical information. And I would challenge you in those moments to ask families to pause and go one step deeper. Tell me about your child, not their medical journey, not their illness. Tell me about them. Tell me about what a good day looks like. What has been the most difficult part of this journey for you? What has this really been like for you? The next question we always ask is about the medical information or that wall behind. We often see clinicians using what we call a bulldozer method, where because it is what we know so well, we spend years learning the medical information. We walk in every day and we tell them, we know how sick your kid. We tell them all the numbers, we tell them all of the vital signs and labs values and what it all means. But when we use this alone, it really begins to become a cudgel. We have to know where we're going and what we're hoping for to be able to move forward. And so the next question we ask is about the foundation that the family is standing on. What does your support system look like? What are your values as a parent? And this is often one of the main goals, other than learning about the child, of my first meeting with a family, is to understand what their values are so I can learn what the foundation of how they're making decisions really is. And thinking about parental values has really expanded into a whole body of literature known as the good parent literature. So sometimes I'll even ask families, what does it mean to you to be a good parent? Because what we know is that each family has different priorities. For example, some families might think it's most important to make sure that their child knows that they are loved no matter what. And some families might feel like to be a good parent, I need to leave no stone unturned when it comes to seeking medical treatment options. And every family is different in that. And if we don't ask that question, we won't know where they're coming from. Next, if we actually want to move forward, we have to think about where we're going. What are we working toward? So I often ask families, what are you hoping for? What are our goals? And not only does this help us understand where we're going, it also helps us align ourselves with the family because we can say, wow, I'm hoping for that too. Because every family is different. Every family has different goals, and every family perceives suffering differently. Really, every family does want comfort, but the question is, what else do they want, and what is most important to them? And then finally, to complement this, we think about the ceiling. What are the fears and worries that you have? And this sometimes helps us elucidate goals and understand really where families are coming from. But in combination with these 5 questions, the hopes, worries, and values, this allows us to align ourselves with the patient and family and create a space to give recommendations based on their values and preferences rather than based on our own hopes, goals, or biases that we might have, which might not end up being the same as the families. This kind of understanding that we gather combined with our expertise as clinicians using that medical information allows us to steer families toward a path that we think is right for them based on their own values and hopefully a path that minimizes decisional regret because ultimately those families and the parents, the ones who are making this decision, they are the ones who have to carry a child's legacy after the death, not us. Eric Cassell, who I referenced earlier, said similar to scalpels for surgeons, words are the palliative care clinician's greatest tools. Surgeons learn to use their tools with extreme precision because any error can be devastating. So too should clinicians who rely on words. And so what we know is our language matters. And there are some words that are commonly used in our day-to-day language as clinicians that might send the wrong message to patients and families. We often say we can offer treatment X, Y, and Z, or we can do nothing. And when we say do nothing, that really implies abandonment to families. So it's instead important to reassure families that we will be there to support them through the entire process, no matter what treatments they choose. I think similarly, the phrase withdrawal care implies abandonment with the worry that we won't care for the patient and family after the treatments have been removed. And so a more neutral phrase might be to say separation from the ventilator or removal of artificial nutrition and hydration. Sometimes we also ask families, what would you like us to do? And I often hear this question posed for decisions around resuscitation status, especially, but this really leaves the burden of decision making on the family. So, how can we use the core questions we have asked families to help us guide decision making and use phrases instead like, based on what you've shared with me about your child, I would recommend, and we can guide them in that way. So, as you just heard, there are so many things that impact decision making. And sometimes we try to skip ahead and just do things because we can, or that's the best treatment, and not necessarily because we should. And I think that this is a huge misconception in palliative care. I want to clarify that nowhere did I say that we shouldn't, because so often we get phone calls asking us to, come in and get a DNR or help the family decide to withdraw the ventilator. But really, a choice is only a choice if it's a choice. And so, if we're going to be disappointed when a family chooses X, Y, or Z, then it wasn't really a decision that we should have offered. In fact, we know from the data that parents often opt for continued treatment of underlying disease even when there is no realistic hope for a cure, and they're motivated by hope for a miracle, a desire to extend life, or hopes of palliating symptoms. And we have to be there to support them in that, no matter what they choose. And if it's not a choice, we shouldn't offer it. So the next key component of palliative care that I wanted to share with you is one that you might not think about often when you hear the word palliative care, but I can honestly say that as a palliative care pediatrician, this is something that I spend the majority of my day thinking about, and that's hope. This mural is painted on the walls of our hospital, and it's called Where Hope Blooms. So we obviously, as an institution, have recognized that hope is so important. For parents of seriously ill children, hope is a coping mechanism. It gives a sense of purpose, and it's a source of connection and support. And most importantly, hope is a balancing mechanism. So what do I mean when I say that? Historically, we've used this swinging pendulum that you can see here to describe the way that families oscillate between hope and reality. Because often as clinicians, we hear families express their hopes and we hear them saying, I'm really hoping that, the baby is able to get off the ventilator. And we as physicians don't think that's realistic, or as clinicians, we don't think that's realistic. And so we conclude they just don't get it. When in reality, even families who hope for a miracle fluctuate between expressions of this hopefulness and expressions of acceptance. And I think the problem with this pendulum model is that implied tension that we see between sustaining hope and expressing prognostic understanding. It really creates strain between acceptance and denial. And so because the ball can't exist at both ends, we really don't see patients and families as being able to exist in both spaces all at once. And if we use this model, it's easy to deem parents who are swinging at one end of the pendulum as in denial or unrealistic or at conflict with the medical situation. So we've developed this new model as a field. There's a paper that was published where bereaved parents created a reimagining of the pendulum that they described previously as a way to illustrate the simultaneous coexistence of hope and prognostic understanding. And so when we hear families expressing hope that isn't realistic, we can meet them where we are and align ourselves with them. We can say, I'm really hoping for that too. I hope for that miracle. I'm wishing for that. We can use I wish and I worry statements. We can respond by saying, yeah, I really wish for that. And then share our worries. And I worry that it might not be possible because of X, Y, and Z. And then we can ask them, knowing what you know, what I've just shared with you, what are you hoping for? We can say yes and help them to kind of elicit all those different hopes along all the entire illness trajectory that they want. And so when creating this model, when asked about this concept of hope and reality, one of the parents said, and I love this quote, partner with us and witness the transformative love of hoping for the impossible and the improbable, while accepting the painful reality that our rare and beautiful child is gracefully exiting this world. Something else that bereaved parents have taught us so much about is regret. And often we tell parents, I wish I had a crystal ball. I wish I could tell you what will happen in the future. But in reality, I think we need to think more about regret and use anticipatory guidance to help families navigate those next steps. Because what we know is that regret in parents and caregivers who have lost a child leads to higher levels of anxiety and depression, more days missed at work, worse quality of life, and higher mortality rates. So what exactly do patients and families regret? What do we need to be talking about? They often regret choosing that final treatment, especially if it's unlikely to work. But interestingly, for caregivers of pediatric patients specifically, they regret not choosing that final treatment. And I think that's part of that value system for some parents of leaving no stone unturned, like we talked about earlier. They regret not talking about death or choosing the wrong location of death. They regret not getting to say goodbye. And we all have an important role to play in grief and bereavement because we are a critical part of the family's journey. And what we have learned from bereaved parents is the importance of strong and ongoing relationships between healthcare providers and bereaved families, even after the patient's death, and the effect of negative experiences between healthcare providers and families on parental grief because we know it's more complicated when the experiences were negative. And we also know about the importance of the institution's role in the grief journey of the bereaved parents, which is why we have our Day of Remembrance and we think about how we can best support bereaved families as an institution. Another huge part of attending to suffering and our role as a palliative care team is really symptom management. And what we know is that symptoms in children with advanced illness are really common and they're highly distressing and associated with a decreased quality of life. And so we're going to briefly walk through an approach to pain management, which is not a one-size-fits-all model, but I'll try and hit some of the highlights for you guys. First, just like any other medical team, we do an evaluation. We take a history and we perform an exam. Then we treat any underlying causes as appropriate based on the patient and the family's goals and where we're at in their treatment course. Next, we really use the interdisciplinary team as much as possible to address symptoms. As you saw with the concept of total pain, there is so much more that plays into pain than what can be treated with medicine. And so we're often using our interdisciplinary team to provide family support, psychoeducation, counseling, massage, music and art therapy, and so on. And then we start with basic analgesia like Tylenol and NSAIDs, but you all aren't usually calling me for that. Next, we use opioids, which still play a major role in treating pain. And we rely highly on methadone, especially on our team, because it targets multiple receptors at once, mu receptors, NMDA, and SNRI, and is therefore able to be pretty opioid sparing and used at much lower doses. Next, we think about gabapentinoids, and I can say that gabapentin is one of the most commonly used adjuvants in my practice, especially for patients with severe neurologic impairment. Often we'll reach for TCAs as well, especially in patients who have feeding tubes and have visceral hyperalgesia and feeding intolerance. I often think about when patients have feeding intolerance, neuropathic pain, because most patients who have feeding tubes have disruptions of that brain-gut axis because of changes in the way that their nervous system works. Next, I think about alpha-2 adrenergic agonists like clonidine, and then in the ICUs, you all are using dexmedetomidine as well. I think about NMDA receptor channel blockers, and we already talked about methadone a little bit, but also in this class is ketamine, which can be quite opioid sparing. And then I think about other adjuvants like benzos, SNRIs like duloxetine that I'm using especially for neuropathy. And then the last resort is palliative sedation therapy, which is a whole talk in and of itself, but very rarely needed. I would say in my training, I've never experienced a case, but something that we do only at the end of life for patients who have severe refractory symptoms. So with that being said, all families deserve access to high quality specialty palliative care. And please remember, we are not the fire.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
So refer early. We are here to help.
Hi. We got a call that this house...
And the last thing I want to say is what a privilege it is really to stand next to families each day and watch them hold their hope in the face of serious illness. And so I'll end with this poem by Emily Dickinson. Hope is the thing with feathers that perches in the soul and sings the tune without words and never stops at all. And sweetest in the gale is heard, and sore must be the storm that could abash the little bird that kept so many warm. I've heard it in the chillest land and on the strangest sea, yet never in extremity it asked a crumb of me. Some additional sources. Thank you all.
All right, thank you, Dr. Weber. Question, can you speak on the importance for physicians to be comfortable sharing a diagnosis or the progression of the patient's diagnosis and what that looks like or means for the patient?
Yeah, I think we talked a little bit about thinking about how we create and sustain a therapeutic alliance. And what we know is that families value honesty, and they need that information to be able to make treatment decisions about what the next steps might look like. And I think one of the biggest barriers to sharing that news is often, like I spoke about, the fear that will cause families to lose hope or will disrupt that kind of therapeutic alliance that we have. But what we know is that while families, they might have emotional responses or be upset by the news, they're not upset with their providers, and they're able to maintain and sustain hope even despite that news.
And are you available as an outpatient provider?
Currently, no, I'm not available outpatient just because of capacity. We have such a large consult list currently. We have anywhere from 30 to 50 kids on our list every day. But we are hoping to eventually expand into the outpatient realm. There is an outpatient service that's available, a community-based service called Courageous Kids. It's Courageous with a K, and it's through hospice. But we do not currently have any outpatient services.
And just so everyone's clear, the 30 to 50 patients on your list, it is not all patients that are end of life.
Correct. Most of the patients on our list are not end of life. The majority are not end of life.
Okay, so can you kind of speak to those patients just so our community has kind of the idea of what you can do?
Yeah, I think kind of going back to that slide that I had that showed the roadmap of all the different places that we're integrating with patients and families, we're really providing longitudinal support throughout the illness trajectory, especially for patients with high-risk diagnoses or complex medical conditions. Any patient where quality of life really is disrupted by their illness, we are trying to help interface with. And so the majority of those patients are somewhere else along their illness trajectory, but need that extra layer of support to kind of work through some of those things.
So you're a resource for complex diagnoses like single ventricles or cancer, basically, and you're consulted on all those patients.
Correct.
Yes. Okay. Can you speak to the role of palliative care for families of children with chronic illness, special healthcare needs?
Yeah, I think those are the patients that we're really doing a lot along the entire illness continuum for, being present at their diagnoses, whether they have a brain injury in the NICU, and then providing symptom management, having goals of care conversations, because those patients and their families are often facing so many medical decisions throughout their illness trajectory. And so we want to be an extra layer of support as they think through their goals as a family and what they want life to look like. And also having some of those quality of life discussions about like what makes the most sense for patients, that patient and their family.
Great. Okay. One question about a provider who loved the comparison of having empathy versus sympathy. Can you give an example of what it looks like to share alongside with a family while maintaining boundaries and keeping the focus on the patient and family?
Yeah, I think this is something that's so difficult, especially because we feel so deeply for our patients and their families. One thing I think about when you ask that question immediately is like what kind of emotion it's okay to show in front of families. And what I always tell learners who rotate through with us is that it's always okay to show emotion in the room, and families really appreciate that. And tears are something that I can say probably happen for me like frequently, and that's okay. The problem becomes when the focus gets shifted to us. If we're more upset than the patient or family, then I think that's when we need to reevaluate and maybe take a break or take a step back and think about how we can reshift the focus to the patient and family. I think having boundaries is something that's difficult. You heard the question, do you provide outpatient services? And that's kind of a boundary we have a team have had to draw because of the number of and capacity of the team and the number of patients that we already serve. But of course, we always want to be doing more. Did I answer that well? Is there anything else?
Probably asked the wrong person.
That's fair.
Um, Let's see, and so your role is mainly in the hospital. And these patients eventually go into the community, back into the community. So, do you communicate with their private MDs in any way?
Usually, if we want help with outpatient or community-based palliative care, we're really closely in contact with hospice's program, Courageous Kids, to kind of help provide long-term continuity. We will communicate with primary physicians if we need to, or if we need to pass off medications, things like that.
Okay, and a question about who consists of who's on your support team? How could there's someone finishing their CMHC internship? How could I offer my services or support?
Yeah, currently our team is consists of a physician, myself, a nurse practitioner, and two nurses, as well as two other physicians who do limited time on our team. Um, our goal is to become more interdisciplinary, and that's part of our long-term kind of plan for our team. We're currently working on hiring a social worker, and our hope is to have chaplain support, spiritual support, have child life support to work with siblings, have psychology, maybe even to kind of help with bereavement and long-term relationships for mental health support for patients and families. Um, I would have to learn more about the training program that was mentioned to know how you all could best be in support of our team.
Okay. And I think we had your email somewhere at the
Yes.
beginning. Yes. Um, and there's a question about the slide deck. Uh, we'll figure out how to make the slide deck available for you all, and that'll have your email on. See, I thought I had one more question, but I kind of blanked on. Oh, your symptom management. So gabapentinoids, I don't understand the pathophysiology of that. How do they help?
Yeah, good question. I don't think we fully understand the mechanism of action of gabapentin and pregabalin completely. What we do know is that it maybe works on NMDA, maybe on SNRI, but we know that they are one of our most effective tools for treating neuropathic pain. And so we're often using that in patients, like I mentioned, who have disorders of the brain gut axis, so that visceral hyperalgesia, who have severe neurologic impairment. We also use it for people who have neuropathy as a result of their treatments. We see a lot of neuropathy and heart failure, which I know is your realm, Dr. McDonald. So we use gabapentinoids frequently.
And how long till you see effect?
Gabapentin, we often have to titrate up to see an effect. Usually we start at about 5 mg per kg per day on gabapentin, and we escalate by 5 mg per kg every 2 to 3 days. If we're going pretty rapidly, it usually takes us getting between 15 and 30 mg per kg per day to see effect for patients and families. But for kids with severe neurologic impairment and kids less than 5, we often have to get up to 45 to 60 mg per kg per day. And there's good literature to support that those patients need higher doses.
Okay. And last question. So if you were able to secure a second physician in your on your team, where would you expand your services to?
Oh gosh. I think first we would work on really providing a more continuous realm of care into the outpatient setting and being able to embed in some of the clinics. I think right now we're missing a lot of, for example, cancer patients who receive most of their treatment outpatient, even ones who are high risk, like our brain tumor patients, which is a huge group of patients who have a lot of morbidity and mortality. So I think that would be our first step, in addition to providing some more coverage, whether that would be like a call system or something like that, so that we're available to help more with symptom management versus just being a Monday through Friday service.
All right. All right. Thank you, Dr. Weber. That's all the questions, and that was a great answer.